Okay, good evening, ladies and gentlemen. Thank you very much for coming along to our evening on pain. I'm Dr. Alan Schell, part of the Wolper team, bringing you these events. We'll have 5 events this year. This is the first, and certainly a very important topic for many, many people in the audience. We have the pleasure of a number of people tonight. We'll have Professor Paul Glare, Dr. Martine O'Neill, Professor Richard Chye and David Marishel, and they'll talk about various aspects of pain management, what is pain, how do you manage pain, understanding pain. And it's said if you also were lucky enough to get some of the brochures out there by a group called painaustralia.org.au, Paul will talk about that shortly, then you'll know that it's considered that in Australia, about 2/3 of the population aged 15 years and over have reported experiencing some sort of pain in the past month. And I'm sure some of you are probably sitting here having pain, probably from some form of arthritis. As a GP, we'd say about 10% of general practice is managing arthritic pain. I've had my hip and my knee replaced, and I can say I'm very pain-free. So the end point for that particular problem may be a joint replacement. For some people, even having that, they may still be in pain. Chronic pain is probably the worst, and there are many ways to treat it and not to treat it. And of course, there's some unwanted side effects of some of the medicines that we do take or get across the counter. And of course, the most recent one is the change in codeine prescribing across the counter, etc., and the opioids. So I'm going to introduce you to Paul Glare, who's going to talk about, Pain Australia and some issues around pain management. Please say hello to Professor Paul Glare. Thank you.
Thank you very much, Alan. I'm not actually giving a formal lecture like my 3 colleagues who are going to speak to you. I'm really here just to tell people a little bit more about Pain Australia. I recently became one of the members of the board of Pain Australia. I joined the board to take over from Professor Michael Cousins, also my work predecessor, who recently retired from the board. And I mention him because he was very important in setting up Pain Australia. Pain Australia is a non-government organisation that came out of the National Pain Summit back, that you may not remember, back in about 2010 in Canberra, which really identified what a big problem pain is in Australia, like Alan was saying, and how access to good pain treatment was very limited. And so out of the National Pain Summit, there's a National Pain Strategy and an action plan, and the job of Pain Australia is try and advocate for getting that implemented. And probably the biggest achievement of Pain Australia recently is to get the current Commonwealth Government to support the implementation of the action plan as a concept. They haven't put any money towards it, but they've certainly said that it's important and they want to see it happen. So I'm not here to say who to vote for, but they at least seem to be in favour of the National Action Plan on Pain. I don't want to steal the thunder of my colleagues who are going to speak in a minute, but like Alan said, pain's a big problem. Estimated to that chronic pain, which means pain that's been there for more than 3 months, affects about 20% of the population in Australia and about 1/3 of people over the age of 65, like you said. So you can do the maths and work out that it's millions of people affected. Probably about 10% of people with pain actually having really a major impact. And I think these days we're more focused on the impact of pain on functioning rather than just purely the pain number. Yeah, but I think the other point to make why it's an important priority is that there's also the cost of pain aside from the individual suffering, and it was when those statistics were put together about 10 years ago, it was also estimated that pain costs the Australian economy a lot of money. Anybody want to guess how much money chronic pain costs Australia each year? It's in the billions. Yeah. Well, my hearing's not as good as it was, but it's basically $34 billion a year, believe it or not. About half of that going on direct medical costs and the other half on lost productivity. And the final couple of points I make is that It's twice, people with chronic pain are twice as likely to be admitted to hospital, and sadly, people with chronic pain twice as likely to commit suicide. So, the goals of Pain Australia are to get the government, state and federal governments and other organisations to make pain a priority, to make sure that people know about pain, and that's why we're supporting this event tonight, to educate clinicians about pain and why it's important and how to treat it, and to make sure that there's access to interdisciplinary pain management. So that's why we have physicians and a psychologist speaking here tonight. So anyway, like Alan said, we did provide some materials. There's more people here than what I was expecting. If you didn't get any of the printed material, you can go to the website. It's painaustralia.org.au. There's lots of resources. If you want to get more involved, you can. If you want to give them money, they'd like that even more. So anyway, without further ado, I'll pass over to my colleague, Dr. Martine O'Neill, via Alan. Okay. Thank you.
Thank you, Paul. Dr. Martine O'Neill is our first guest speaker. She's an anaesthetist and certainly is a pain medicine specialist. She has qualifications in anaesthetics in particular, working at St Vincent's Hospital, Royal North Shore, and she's been involved in the International Society of the Study of Pain, looking at persistent pain conditions, and applies a multidisciplinary approach to assessing and managing pain. Her talk tonight is Pain, What Is It and What It Isn't? Over to Martine, please. Thank you, Martine, for a very good overview of pain and most of the topics that we're talking about tonight, and for the plug for Wolper and our Move Well program. And certainly Wolper goes through many of those things. We offer Tai Chi as well. Tai Chi has been helpful, and certainly the Move Well and regular exercise is something that one should consider. Our next guest speaker is Professor Richard Chye, who is very well known to Wolper as a friend and a visiting specialist in palliative care, staff specialist and director of the Sacred Heart Supportive and Palliative Care. He's been working in palliative care for many, many years, and certainly was instrumental in setting up a number of clinics and societies, and in fact is a member of the Australian Advisory Council on the medicinal use of cannabis. So we've all heard about medical marijuana as being another offering in pain management. And so Richard is going to talk about, besides other matters, he's going to talk about the role of cannabinoid or marijuana therapy to assist with pain management. Over to Richard. Thank you.
Thank you very much, Alan, and thank you to Wolper and Pain Australia for the opportunity to come and talk to you about this. So yes, my talk is about whether cannabinoid therapy or medical marijuana is useful. And I'll talk to you about, these are my conflicts of interest. So yes, I do talk a lot about for lots of companies as well. Yes, I might have to talk very close. Okay. So you can see that I do work for lots of pharmaceutical companies as well. But I guess interestingly also, I also have been providing lots of information to many marijuana companies as well. And they've all asked questions about how they can market, how they can use their products as well. So I've been asked by lots and lots of companies about that as well. And you can see that I'm also part of the Australian Council on the Medicinal Use of Cannabis. So we're helping government, the Commonwealth government, to put cannabis in its right place in terms of where its role is. There are lots of companies, and in America, for example, there are buses that go around, in a way, sometimes what people call peddling their marijuana for lots and lots of things. And this is a picture from Long Beach, where you can just go into a clinic and obtain your marijuana. And I'll explain to you what type of marijuana you may actually get from these sort of groups. So my topics are a little bit about the cannabinoid system, but also the evidence, or perhaps the lack of evidence, and to tell you that cannabis is still very much a medicine, and we should consider that marijuana is a medicine and not to be considered for anything else. So the cannabinoid system has been used for thousands of years by lots and lots of people in China, in Mesopotamia, in Egypt for a long, long time, and used even in medicine in the early 1900s. It was only because of its starting to understand that it has an addictive nature to it that governments in Australia, in Canada, in US, and the UK then started to take it off the prescribed pharmacopoeia that doctors used in the 1930s. Cannabis is actually derived from plants, from different types of cannabis plants. And they are, in fact, in Australia, a source of hemp. And they are grown extensively in Australia for their fibrous material, for building, for clothing. And also for hemp seed, they're used for lots of other non-medical but health foods as well. Body Shop now, for example, creates a hemp cream to try and take on its popularity of what it may mean to lots of patients. But it's also used for cannabis. But cannabis itself is a female flower and contains lots of psychotropic agents. So THC is the one that we talk about. And it's the most widely used recreational drug of abuse around the world, but also used, called in many, many names as well. But cannabis, the plant itself, has more than 400 different molecules, of which 70 to 90 of them have some form of psychoactive effect on patients, on us, on animals. And again, there are lots of other chemicals there as well that make up the plant. And cannabis does interact with lots of body systems in our brain, in our body, that regulates how our body actually works. And yes, there are lots of ways that can be used as an analgesic in some cases. It can be used as anti-spasticity agent. It can help mood. It may help with cognition or impair cognition. It is also involved with the brain reward center as well. And that also has a significant place in terms of opioid addiction and in chronic pain, for example. The lack of evidence, however, of its marijuana use or cannabis use is very evident. Yes, it is used in lots and lots of different things. And, however, the evidence behind it is very limited. You can see there are a whole host of things that it can be used for. Not completely tried and tested in all those areas, but have been used and have some improved benefits with patients from these conditions. And you'll hear the positive stories that marijuana, cannabis has in those conditions. What you don't hear, however, is when it doesn't work. And that's what I think we need to also understand as well. The Therapeutic Goods Administration in Australia has put out 5 guidance documents to help doctors understand where the role of medicinal cannabis may be in treating specific conditions. But right at the bottom, the site, if you Google TGA, medicinal cannabis, you can also get information which is directed at consumers, directed at patients and carers. So it gives you a better understanding of where marijuana may actually be. So in non-cancer chronic pain, there's a specific guidance documents that help doctors to try and understand what the role of medicinal cannabis is. And from that, there are lots of different things that I'll start to talk to you. So yes, I had a 70-year-old lady who had very bad arthritis in her back, and she also had pinched nerve with pain going down the back of the leg. And I'm sure all of you would know this scenario. Some of you have gone through this scenario as well. And yes, I gave her cannabinoid therapy as an oil because all the other medications that she's tried didn't really help. Did it help her? The answer is yes. Her sciatica pain improved, her nerve pain improved, but her arthritic pain did not. So it works for some pain, it doesn't work for every pain. Overall, those guidance documents have said that cannabis can help patients with non-cancer pain, likely to achieve about somewhere between 30 and 50% improvement in pain compared to, say, placebo. That's the overall evidence so far. So in other words, yes, it helps pain, it doesn't get rid of pain. And I think that's a very, very important distinction. And that, as I said, for musculoskeletal related neuropathic pain, nerve pain, so not arthritic pain, a 30% reduction in pain, and perhaps overall there may be a 50% reduction in pain for non-musculoskeletal, meaning other types of nerve pain, like neuralgia, trigeminal neuralgia, peripheral neuropathy, things that my previous speaker talked about. This is what you get from Long Beach. What do you choose? What would you choose? And the answer is, you don't know. Yes, in Canada, all you need is a doctor to write a referral saying, yes, this patient has this condition and cannabis may help. The patient takes that to a dispensary, and it's usually a high school student at the back of the dispensary that says, oh, maybe vanilla kush is the one that's right for you. That's what's happening in North America. However, what is in all of that? In the Netherlands, when they looked at the cannabis that you can get from the coffee shop samples or dispensaries, you can see that there are lots of bacteria in it. There's lots of fungi in it as well. Your friends who are having chemotherapy for cancer, do you want them to take bacteria and fungi whilst they're having chemotherapy? Think about that. In the United States, so this is a paper in 2013, so not that long ago, when they burned the cannabis, like when you are smoking the cannabis, and they tested the smoke, they found pesticides in the smoke. So patients are inhaling pesticides that are not got rid of even though you burnt the cannabis. There's one called here permethrin, right down here. We use that in Australia to prevent termites. Do you want to inhale something that we use against termites? So yes, it also depends a lot on, the cannabis depends a lot on the species itself. So yes, back in the 1950s, when cannabis was confiscated, it usually was a 50-50 THC-CBD combination. And yes, the THC is the one that makes people high, and the CBD is the one that reduces that high. But as people got more innovative, now drug seizures show that most illegal marijuana are predominantly THC because patients want the high. The addicts want the high and no CBD. So that's why CBD-only products are actually very expensive to make nowadays. The Lambert Initiative at University of Sydney, you remember all those little children with epilepsy who their parents would buy cannabis oil for their children to combat their epilepsy. And all of them said they were all CBD only. Well, when the University of Sydney tested those oils, they found that the CBD levels in those oils were very low. And that almost all of them had the THC, the one that makes people psychoactive. So what's on the label doesn't mean anything. It doesn't mean what's inside. So lots of parents were buying lots and lots of oils from illegal sources and not know what's in it, whether there's bacteria in it, whether there's heavy metals in it, whether there's pesticides in it. Imagine trying to give those things to little children. In that study, some of the oils had no cannabis at all. No THC, no CBD, nothing, just oil. So our legal practitioners are preying on those vulnerable people. That's what that industry is like at the moment. Do we want to support that? So yes, their conclusion was profound variation in illicit cannabis in Australia. Not necessarily Canada or North America. This is in Australia alone. So what are the adverse of cannabinoid therapy when I use it for nerve pain? I tell patients, yes, drowsiness is the most common effect, and that's why I give it in the evenings. I give it at night. And therefore, most patients will tell me it provides them with a good night's sleep. Martine has already talked about having good sleep as an important healing component of pain, helps you cope with your pain. And in fact, a lot of my patients, some of them will say, look, they make them feel drunk throughout the day, but other patients will say to me, they've had a good night's sleep and they become much more wakeful during the daytime. I don't know which patient will fall into which category, but those are the things that patients have to understand. There is an association with developing schizophrenia. Yes, there are associations that observational studies have provided. So yes, there's a risk of developing schizophrenia. However, the doses that I use, and if you're likely to be over 35, then the chances of developing schizophrenia are therefore low. But because of the THC, yes, patients will get psychotic or hallucinogenic. And that's happened once for me as well. So it's not a risk that's completely zero. But with the doses that I use, the risk is relatively low. There is a risk of dependency and also addiction as well. But in patients that I have stopped their marijuana cold turkey at the doses that I use, I haven't got anybody who's gone through a withdrawal process. So therefore, the risk of addiction and dependency while it's there is also very low as well. These are the lots of different side effects. So that's why I say that marijuana, cannabis, has to be considered a medicine. So you can see a whole host of things there, like nausea, like somnolence that we talk about, dizziness, tiredness, vomiting, even though it's also used to try and prevent nausea from chemotherapy. By itself, it can cause some nausea, and lots of other things as well, as you can see. This is what I also tell my patients, that even though, this is from New South Wales government, even though I give my patients a letter saying that they're on cannabis that's properly supervised by myself, and I give them the letters from the Commonwealth government and New South Wales government to say that their cannabis is authorized, one arm of government hasn't talked to the other arm of government, as you all know. So New South Wales Police actually states that there is no medical defense if you are found to have THC in your saliva. So there are some patients then who will say, I will prefer to put up with my pain rather than take cannabis. And yes, I've had patients who have taken cannabis, their pain has improved, but when they found out about this, or when I tell them about this, they decided to put up with the pain rather than change their lifestyle. Because giving up driving is not easy. Yes, you can write to your local member to say that the New South Wales law needs to change, but I suggest that you do it after the elections. Your local member may not be there come March. So in conclusion, yes, we talked about chronic pain, and cannabinoid therapy is just one medicine that we can use to help pain. It is not the panacea. It needs to be part of what Martine has talked to you about as an interdisciplinary approach to helping you with pain. It's seen as a drug of last resort. The government will only give me permission if the opioids haven't worked. They will only give me permission if the gabapentin, the Lyrica hasn't worked. They will give me permission if the tricyclics or the pain injections or the nerve interventions have not worked. Then they're happy for me to try cannabinoid therapy. So it's seen very much as a drug of last resort, not the first resort. Yes, it can improve pain, but it will not get rid of pain. It will not get rid of pain. It will help you make pain less and more tolerable and allow you, therefore, to do more with less pain, to be more functional, as Martine has talked to you about, to do more for yourself. Not all pains will respond to marijuana. Mostly nerve pain, arthritic pain less so. And as I mentioned, it has to be considered like any other medicine. It is a drug. It has benefits, it has side effects. We need to be very, very mindful of that. And when I talk to patients, I show them all the risks before they sign up. Thank you very much.
Thank you very much, Richard. And as Martine has done so well for us tonight, we're now going to look at the psychological issues around managing your pain, what your brain is thinking, and what we maybe can change as attitude to the pain. So I'm going to introduce you to David Marishel, who completed his Bachelor in Psychology, Master in Psychology, involved in cognitive behaviour therapy, motivational interviewing, and is also part of a clinic that he's running in the Inner West in pain management. He worked at Royal North Shore Hospital, University of New South Wales, Prince of Wales, and is in private practice in Newtown and in Edgecliff. And David has experience in assisting people with a range of issues including depression, anxiety, stress, chronic pain. So tonight he's going to talk about taking control of pain. Over to David. Thank you.
Good evening. Can everyone hear me? Okay. All right, that sounds good. So that is quite a big screen there. I haven't ever seen my name up in a screen. This is probably the closest I've got to being in film. So as you just heard, my name's David Marishel. I'm a clinical psychologist. And most of the work that I do is with people who have serious health conditions, and chronic pain is one of the largest areas that I work within. It's great to be here at this wellness event, and it's great to see so many people here coming along, despite the bad weather today, to do something and do something positive to better manage your health or to help somebody else that you know. I must say that tonight, I must admit that I'm not here. I'm here from my enthusiasm for the area of health psychology and not my enthusiasm for public speaking. As you can imagine, as a psychologist, I spend most of my life talking to at least just one other person in a very small room. So this is a little bit different. And what I'm hoping to do is to bring something of what I talk about in much smaller rooms to you, to helping you or somebody that you know get unstuck from pain. How's this microphone going? It sounds to me like it's going in and out. Okay. Taking control of long-term pain is not just about managing... Oh, I'm just going to take a minute here to make sure I can work on that. Taking control of long-term pain is not just about managing physical symptoms. The impact of pain for many people can be widespread and overwhelming. The kinds of things I often hear from my clients is that they have difficulty sleeping, disruption to their daily activities, difficulty walking or working or studying, low energy level, poor concentration, withdrawal from social activities, and so on. The psychological impact of this is often anxiety, loss of enjoyment in activities, frustration and anger, loss of hope, guilt, stress, and feeling misunderstood, judged, and alone. I strongly believe that when pain impacts people's lives in these ways, it does not indicate a personal failure. It certainly does not mean that people are weak or malingering or that the pain is all in their head. Those ideas are absolute rubbish. It is simply a reality that living with long-term pain, chronic pain, is a massive challenge. So let's begin to have a look at some of the ways we can tackle the problem of long-term pain. One of the simplest ways to take control of pain, as has already been mentioned tonight, is to understand how pain works. So the science has come a long way since I think probably since the mid-1960s, if I'm getting my history right, to unlocking some of the mysteries of pain However, most of us still see pain in a very primitive way, which has already been described tonight, that the body hurts and I need to do something about it. I need to fix it. Pain has a way of prioritizing itself. And with short-term pain, as we've already heard, this is fine, we need to do it. With long-term pain, this approach doesn't work so well. And we can get caught up in an ongoing struggle of pain and distress. Without going into detail, I just wanted to flag one of the most useful concepts that I think about with people, and that is that the brain can turn the intensity of pain either up or down, a bit like a volume control. And this is what was referred to before as sensitization. So some of the things that we know that can change the volume of pain include our thoughts and our attitudes towards pain, our emotional state, our stress level, our sleep quality, and changes in our activity level. Also, I put it there, yeah, how socially connected or disconnected we are can also impact on the level of pain that we experience. And I believe there's some research out there that I've come across that shows that people who are more socially connected have less impact from pain in their lives. So when we can't fix the body, we can take steps to improve our emotional state or reduce unnecessary stress. We can work to improve our quality of sleep. We can take a look at our thoughts and attitudes about pain, and we can be more active in the things that we love and more connected to the people around us. Now, I want to be clear that these things are easier said than done. I'm sure there's a few people here that are sitting there thinking that right now. And in a lot of ways, these things are also counterintuitive. For example, when pain is present, the natural human response is to withdraw and move away from our usual activities until the pain eases. But when we withdraw, we start to focus more on the pain, and we become more sensitive to pain. The research tells us that people can turn the volume of their pain down, slowly, steadily, patiently. People can shift the focus away from the part of the body that hurts and towards the things that are meaningful in life. So once we've upskilled ourselves and we've learned a little bit about how pain works, a good starting point is to explore what goes on in our heads when pain is present. As psychologists, we often look at how our thoughts, our feelings, and what we do or our behavior are all linked together and interact. This is often a good starting point. How we think impacts on how we feel and behave, and how we behave impacts on how we think. It's theoretically not possible to change how the body, or I don't think it's theoretically possible to change how the body feels without actually changing our thinking or doing something. So if this room is very, very cold and we all feel cold, we can't just feel warmer without thinking differently about how cold we feel, or perhaps doing something like putting on a jumper. So using this theory, we can attempt to take control of pain by managing our thoughts. I usually start by considering with people how helpful or unhelpful their thoughts are. And just so you know a little bit what I'm talking about here, I'm just going to mention 3 thinking styles that are very commonly discussed in pain psychology. And those are black and white thinking, catastrophizing, and shoulds. These are things that some of you may have heard of before, certainly would have experienced. Black or white thinking is when we see things in extremes and ignore that our experience is probably somewhere in a grey area. An example of black and white thinking is I can't do anything. So that might be something that a thought that comes up. But the truth is that we can always do something. That's an extreme position. The second thought process I'll mention is catastrophizing or catastrophic thinking. It's probably the most widely researched thinking style in pain psychology, and it's generally associated with intense pain or pain increased, withdrawal, and having a sense of helplessness. So examples that I hear often include thoughts such as, my pain is 11 out of 10. Or if I can't get rid of this pain, my life is over. those are very, very normal thoughts. I don't think they're particularly unrealistic or crazy. They're just unhelpful. The last thinking style I mentioned is shoulds. This is my brain's personal favourite. Whenever we have shoulds in our mind, for example, I should get through this pain, I should be able to get through this pain, I should be a better parent or grandparent, we might be attempting to motivate ourselves, but we're really just being unrealistic and end up with a sense of guilt or anger. So unhelpful thoughts are normal. We all have them. The problem when our thinking is automatic and unchecked. So what I usually encourage people to do is to start to become aware of their thoughts. Sometimes, in fact, usually just by becoming aware of our thoughts, we decrease the amount that our thoughts push us around or influence how we behave and how we feel. And in psychology, we have very well structured and effective ways of getting at what is going on in our minds, identifying the different thoughts, and then either applying a strategy to it or challenging that in different ways. Beyond working to better understand our thoughts about pain, it can also be necessary for some people to look at how their emotions and their life experiences intertwine with pain. Particularly for people who identify as having depression or anxiety, or people who have lived experiences of loss, trauma, or injustice. Understanding these experiences and their relationship to pain can be extremely helpful. So I'm about halfway through here. How's everyone going? Yeah, been sitting for a long time, and I'm wondering whether it might be a good idea to take a bit of a break, just for half a minute. And since this is a wellness event, if you want to just move and stretch the body, if you'd like to stand up, you can stand up. And I'm not a physio. I've got no way of guiding you through any exercises here. So just please be gentle with your body. It's nice to see all the individual ways that people move. So now if you could, it's very short, but if you could please settle back into your chair. Just before I continue on with my slides, I'm going to ask you just to do one more thing for me. And I'd like everyone just to take a few intentional breaths. So seeing if you can breathe right down into the bottom of the belly without moving your shoulders too much. Inhale to about 90% capacity, and when you exhale, exhale as slowly as possible without it being uncomfortable. So almost like you're pushing the air out slowly. Okay, so just taking a few of these breaths, and then we'll come back to it. So I'd encourage everyone to keep breathing, but you can certainly, you don't have to stop. When I say stop the exercise, keep breathing. Just allow it to go to its natural rhythm. When pain is present, we're more likely to experience stress and tension in the body. And as our body tenses up, we're more likely to experience increased pain. This results in a loop of escalating stress and pain. And when stress and pain escalate, over time the body becomes more sensitive and less flexible. So taking the time out to relax and relieve this tension can help reduce pain. The main remedies we have for physical and psychological tension are pleasant activities, exercises and stretching, or we can practice specific relaxation techniques. And certainly things like yoga, Pilates, Feldenkrais, hot baths, golf, acupuncture, yoga. These are all things that I would classify in this category of helping us to relax and unwind from the tension. There are numerous studies that show that relaxation exercises can help reduce pain and improve quality of life. This is not just New Age thinking. The main techniques I recommend, and that's just because they tend to be the most researched, diaphragmatic breathing, which is what I asked you to do just a minute ago, progressive muscle relaxation, and mindfulness meditation. So diaphragmatic breathing is just based on the idea that when we get stressed, our breathing changes. And what you just did then a minute ago of lengthening out the breath is thought to trigger a relaxation response in the body. I generally recommend that people, if you're going to use this technique, do it 2 to 3 times a day for about 3 minutes. Just going to take a break myself. So the second technique I'll mention is progressive muscle relaxation. I won't go into detail on how you do it, but it's to do with tensing and relaxing muscles. If any of you are interested and don't know how to do this technique, if you jump on the internet or YouTube and type in progressive muscle relaxation, there are instructional videos there that will guide you through it. Generally takes about 10 to 15 minutes, and 1 to 2 times a day is enough for most people to get benefit. The last technique I'll mention is mindfulness. It's not exactly a relaxation technique, it's much more than that. I think I saw quite a few people put up their hands, so many of you are familiar with this technique. And I'm hesitant to go into it too much because it is more involved. So perhaps for those of you who don't know about mindfulness and are motivated and would like to learn more, I would actually recommend finding a teacher or a course to help to guide you through this technique. There are apps and you can find information online, but I think this is something that's much better with a teacher. So the take home here is to find something that you can do, find something that works for you, practice it, and make it a routine. Just like we wouldn't expect to have a few violin lessons and then playing in the Sydney Symphony, we need to practice relaxation regularly before we can add it to our pain management toolkit. I was going to talk a little bit about sleep. I think we're probably running a little bit close to time, so it's already mentioned that sleep's a problem. The kind of things, maybe just very briefly, the kind of things I talk about with people are developing good sleep habits, learning behavioural techniques to deal with specific sleep problems, and looking at what people do during the day. So as a psychologist, I'm really interested in thinking about with people, what are they doing during the day? Because sleep is one of those things that the harder we try at night time to get to sleep, the less likely we are to get to sleep. So usually our answers is somewhere in what we're doing during the day and how we think about sleep. Having a sense of meaning and purpose in life is at the core of our well-being. Long-term pain can act as a significant threat to our well-being by making it harder to pursue things in life that give us meaning and purpose. My experience is that people who are really clear on what's important to them can use this as an anchor and find stability when pain is present. Regaining a sense of meaning and purpose in life often involves identifying the things that are important to us, accepting or struggling less with the real limitations that come with pain, and resetting our focus on places where we can find value. And I'd have to say that this is the kind of stuff that I end up wanting to talk about with people. What's important to them, how's pain impacting their lives, and how they can get back to the things that they value. So the last thing I'm going to talk about is about supporting someone who has long-term pain. And this is a massive area. I'm only going to be able to talk about it very briefly, but I'm just going to pick out the most important points that I think about. Many people find it difficult to talk about pain with their partner or their support person. Often the discussion is avoided altogether or only brought up in the context of a disagreement or an argument or when they really need to. When it comes to pain and relationships, feelings of resentment, anger, guilt, and disconnection are extremely common. The conversation that support people need to have with people in pain is very specific to the needs of the individuals and the history of the relationship. That said, there are some things that are worth talking about, and this includes thinking together without blame or judgment about how pain impacts on their relationship, identifying the needs of each person in the relationship, and planning or deciding on how pain is going to be communicated. So the end goal here, I'd probably say that for most, when I do talk to couples, the end goal is usually to work out what each member of the couple need and a shorthand way of quickly understanding that. We want to minimize the conversation, but we want to be able to have the conversation. Just as an example to finish off, I saw a couple recently, it was at the beginning of this year, who were, the person with pain was having a very long flare-up in their pain, a period where the pain was really intense, and it had impacted so much on the relationship that they were facing separation. And neither of them liked communicating. They were completely avoidant of communicating. So in working together a little bit, what they developed was a sign language. And this is probably the simplest method I've ever heard of or seen, where it was a thumbs up for a good pain day, a thumbs down for a bad pain day, and there was something of a thumbs to the side for it was a usual pain or okay pain day. And this is simple, but the effect was quite helpful, that when the partner saw the thumbs down, they immediately knew that it was a bad pain day, that their partner was probably going to withdraw, that they might hear some not so nice or colourful language in the background, and that they knew that the washing wasn't going to get done that day, that the washing was probably going to get done the next day or the day after, so they didn't have to hold that expectation. The last point I'll make is that pain is a shared experience. I think this goes for a community level, but just thinking about what happens in couples. We know from several research studies that support people often experience the stress levels equal to or sometimes greater than the person with the health condition. It is therefore crucial that support people also take steps to look after themselves, look after their health, and avoid burning out. So I think some of these, in fact all of these resources that I've put up there have already been mentioned. So I probably don't need to talk through them. They're as said before, there's many resources out there. The pain book I just put up there because it's the most recently one that I've read, and I think it's really clear. Explain Pain is for people who would like to go into a little bit more detail about how pain works. And on the Pain Australia, I didn't even know that Pain Australia was supporting this event, and I've put their website up there. I think that there's you might be able to tell me if I'm getting this wrong, but I think there's a resources panel, or if you click on that, there's about 4 or 5 videos, and I think they're all very clear and helpful in helping us to understand what's going on when it comes to long-term pain. So thank you very much for listening, and I'll stick around for the panel now.
So as is usual, we'll invite the guest speakers to join us in the panel here, and we know many of you know that the question time, and we'll take questions from the audience. So John, you're welcome to come and join us as well. Paul? Yeah, so got some roving mics there, and we have some microphone over here. So if you're going to ask a question, we can't treat you tonight, but we'd like to help you generally. So if you have some questions about medication, well, that's a bit tough. But on the other hand, you may have some questions about what was discussed tonight. Up the back first there, one gentleman over there will come down later at the front. Speak nice and clearly, please. Ask a question. No comments, just questions, please.
I wonder if anybody in the panel would like to address the issue of unrecognised chronic dehydration in chronic pain, and whether when people try to address that has an effect. And also, is there something to pain that's perhaps important that we should take notice of and that that a certain level of pain may be actually beneficial.
Okay, two questions. One on dehydration, one on is pain beneficial? Oh, just flip on the switch there. Up. Oh.
Is that better? Oh, there you go. I can't speak to dehydration on its own per se, but I can say that nutrition is a big issue in chronic pain as well. And I think that fluid balance would be part of that. More my observation than firm scientific evidence is that patients living with pain tend to neglect nutrition as part of their everyday, and there's a myriad of reasons for that. Medications are certainly one of those reasons, probably mostly because they're causing side effects, and that again has a big impact on well-being is nutrition. Certainly a lot of the medications like opioids and the gabapentinoids like Lyrica also cause profound fluid shifts within the body, and that may in itself also contribute to a sense of unwellness. I don't know if anybody else has got any ideas around that.
That sounds fine.
Yeah.
The other issue is pain beneficial? Other than the expression you talked about that the body's got to fear, it's got to heal itself, that type of benefit, I mean...
Do you mean from the point that I was making at the beginning is to alert you as to threat or potential damage to the body? Is that what you meant by beneficial?
And also for the body itself to produce its own endogenous pain releases. So in other words, to go through a certain amount of pain to allow the body to deal with it.
Yes, there has been quite a bit of work around that, the endogenous opioid system and the cannabinoid system more recently as well, and the benefit that does play in your overall well-being. Certainly though, if you take exogenous opioids, so if you take opioids, then that system is greatly altered and isn't working in the way that it should to provide that wellness for you. And there's a specialist in America called Jane Ballantyne who's taken a real interest in that, because it's true what you say, that for mental health well-being, the endogenous opioid system, the sort of opioids that are within you, are very important to maintain the equilibrium of mood. And so she's quite fascinated with taking opioids as tablets as to how that interacts with that system, and then the negative effect that has on mood. So I would say yes, that I don't know if pain is the thing that is at the bottom of that, but certainly that system is important for well-being.
Okay, question over here. Just Ruth. Paul, yes, please, go ahead. A bit closer.
Well, you know, I don't work for Pain Australia. I'm on their board, but when I do my day job like Martine, I think, you know, this is a wellness kind of program that we're speaking as part of that Wolper's running, and I think definitely I would say two things. Firstly about nutrition, that I think it often comes up in the clinic, and I think there's three kind of issues. One is I think one of the issues with chronic pain, people end up becoming overweight, which just aggravates their pain worse because they don't eat properly, they're not exercising. It's easier to go and get a takeaway than cook food or go shopping, etc. So losing weight is an important thing if you've got chronic pain. Then I think, you know, there's all this stuff in the media now about the gut biome and all you've probably read about, and does what's going on in your gut, you know, transmit up to your brain. And you even hear people, I've got two patients who are planning on forking out up to $30,000 to have a fecal transplant because they think that'll solve their chronic pain problems. And I think that's really crazy. And then the third thing is, I think there's some interest in more on the genetic side, that maybe people have certain genetic conditions which give them food sensitivities. They lack enzymes to metabolize certain foods. There's an interest in, you know, like celiac disease would be one thing. Now there's an interest in histamine sensitivity, and whether too much histamine in a diet might cause certain kinds of pain, migraine and abdominal pain, and maybe chronic pain as well. So I think, and I think it feeds in this whole thing where chronic pain is moving to this interdisciplinary approach, because many people come along to the clinic and say, well, I'm taking all these drugs, but really I don't want to take drugs anymore, you know. I want to be healthy. I read the body and soul thing in a Telegraph, and I don't want to take drugs. I want to, look at other ways to manage my pain. So can you help us with that? So I think that's where chronic pain is really going and why it's.
I think that pain, acute pain especially, is and the body's reaction to acute pain is a very, very primitive reaction. That's what our bodies normally do in terms of reacting to acute pain. If we are close to something that's very hot and we're going to get burnt, we move our hands away, we move our feet away. If we have chest pain, say from a heart attack, we know that we should at least go and find a doctor or go to a hospital to get assistance. So acute pain do have very good primitive reasons for them, is to help remove that, helps the body understand we need to get away from pain and do something about getting away from acute pain. Chronic pain is obviously very different, where there are changes in the brain, and we like to think about where the brain changes to an area that opioids don't work anymore. And that's why all of us talk about moving away from opioids when we talk about chronic pain, because chronic pain occurs in the brain that doesn't respond to opioids. That's the first thing. When we talk about dehydration, the only thing I would say is that opioids and a lot of other medications are very reliant on our kidneys getting rid of the drugs. And when patients get over dehydrated, especially in the setting of my patients who don't eat or drink very much, then those medications, opioids, then accumulate in the body and then can cause exaggerated side effects. So, in other words, being as rehydrated as possible is actually a good thing rather than being too dehydrated. And I think I wanted to make that clear. Thank you.
Okay.
David, a clinical psychologist, do you find that using, nobody has spoken about this, hypnotism, that can help taking pains away or not using certain medications, so forth, can that help at all?
I can answer that question in part. I'm not familiar with the research on whether hypnosis is effective or not. I have, I guess anecdotally, seen a few of the people that I've worked with benefit from hypnosis, but it's not something that I practice myself. I would say I think it's something that a lot of people are fearful of. It's a bit mysterious, so I think there probably doesn't need to be that fear. There is a training program and the science behind it, and I know that there are a few people around who do offer hypnosis for pain management. What I usually tell people is try it and see if it works. From my perspective, and it's just talking to a few people in my practice, is that there's mixed results.
The other thing, though, there is a relationship between hypnotising somebody and actually teaching them a bit about meditation, or them going on to meditation, which also helps reduce their stress.
Yes, I would say hypnosis, I mean, it falls into the category of something being done to us. So it's a passive process, very different from the techniques that I mentioned, where it's an act. It's about us doing something. So this is going a little bit beyond your question, but I think with hypnosis, we're probably leaving it up to the skill of the hypnotist and our ability or our susceptibility to being hypnotized. So if those things are working, then it may be helpful. However, with relaxation exercises, it's something that we can take control of. We can do them anywhere. We can, they're portable techniques and they're active in that we're doing something.
Thank you. Up the back, yeah.
My name is Thomas Lambert Taylor. You should be able to remember me from the walk with Chye, because I was one of your prefects. I'd like to first, I have a number of questions, so I'll just...
Give us just one big one. What's the one big question?
Well, I haven't got a big one, they're small. Would you like me to ask a question?
Yes, please, yes, go ahead.
I thought I'd start with questions with Mr. Marishel. You mentioned that you have some difficulty with public speaking. Well, we run a Toastmasters club
Okay.
in North
Sorry, I
Sydney.
missed that.
He wants you to go to Toastmasters.
Okay, I'll get that on.
It's interesting because just last week I was working with someone on their fear of public speaking, and I was telling them that I was coming here this evening, so I'm trying to practice what I preach in helping other people.
We can see
So
now.
I don't know if that was a suggestion, and thank you.
You can see after this if you wish. Now, on the question of pain being all in the mind, I actually saw Professor Siddle some time ago, and he sold me his book, and I've read it from cover to cover, and I had a problem with pain. So I'd done the walking, I'd read the book, I went back to Professor Siddle, and on the second occasion he said, "I'm sorry, I can't help you." And
So what we suggest is that we will ask all of our panellists who and where good services are that you could get referred to. If Professor Siddle didn't help you, then perhaps a clinic run by David or Martine might be helpful. And we talked about where people can get some of the pain management services. Perhaps you can plug yourselves. Where, David, would you be going? 2 clinics that you're involved in? You're allowed to tell us?
Oh, yeah.
A bit louder.
Sorry, I can. Yeah, look, I work in a psychology clinic in Newtown, which is linked to the Inner West Pain Centre. I also work at a practice in Edgecliff. But I maybe also just to acknowledge that some people do come to see me, and they'll tell me that they've been to see a pain specialist or their doctor, and they've been told that there's nothing more that can be done. That's, I think, a very common experience, and can be extremely crushing for people when they're told that nothing more that can be done about their pain. So that's, I don't know about percentages, but it might be 30 or 40% of the people that I talk to have been told that.
Yeah.
Okay, so yes, over to Martine. We take your point, sir. I think we should allow other people to ask a question, and I think that's a very important question. Where, when you do have a problem and somebody can't help me, Martine, where could they go then?
So in New South Wales, there are a series of pain clinics, public hospital pain clinics linked to the big hospitals, and on the ACI website that I spoke of earlier, and probably on Pain Australia as well, their website, there is information as to where to go. Obviously, you will wait a little bit longer for a public pain clinic. The big ones in this town are the Royal North Shore Pain Management Clinic, which is now called the Michael J. Cousins Pain Management Clinic, and that's linked to Royal North Shore Hospital. And the waiting times there are less than 6 months, I would say. Yeah, they get triaged. It's not as bad as you think. You know, sort of 1-2 years is not the case anymore. I work at the St Vincent's Pain Management Clinic, Prince of Wales, Royal Prince Alfred, St George. They all have public pain, interdisciplinary pain clinics now. And in addition to that, there are several private groups that usually spring up from the public group, quite sort of next door in the neighbouring private hospitals. So North Shore Private has a group. There is a practitioner there are a couple of practitioners at St Vincent's. They're not in a group, but they're together. Prince of Wales has a couple of private pain groups as well. They're all easily found on the internet.
Yeah, I don't have anything more to add about that, but I just come back to this issue about there's nothing more that can be done. And that really is a bit of a false statement. I mean, what they're probably saying is there's nothing more that they can do to reduce the pain score down further. But I think like Martine was saying earlier, we're trying to move away from focusing on, well, I can't do anything until the pain goes away, to, well, I'm stuck with this pain and how am I going to get on with my life? And that's what a lot of the really interdisciplinary pain management is about now, learning ways to, you know, kind of put it simply, how to cope with the pain better while it's there and have it, the actual pain intensity go into the background and, you know, focus more on functioning despite it being there. And the program teaches you how to gradually build up your functional level. It doesn't happen overnight. It has to be done gradually. But you can read a book, but just you can read a book about how to play tennis, and you won't win Wimbledon. You really have to go and work with somebody and show you how to do it. So I think that's if you've been, doctors who do things to people, stick things into them or tell them to take drugs are going to run out of things that'll necessarily take the pain score down, but it doesn't mean that nothing can be done to help you live a functional and happy life despite a bit of the pain still being there.
Yep. Thank you. Last question, because we're mindful of time.
Can you please tell me what are the side effects of gabapentin?
Gabapentin.
They're very similar to Lyrica. They both come from, they're very identical compounds. So a range of side effects, and I'm sure if you read the product, information, it goes on for days. But the ones that are the most important really are the cognitive side effects, so the ones that affect the brain. Memory problems, concentration problems, feeling like you're a slightly different person, drowsiness, falling. These are the sorts of things that we hear a lot with the gabapentinoids, so Lyrica and gabapentin. And then all the usuals that come with any drug, nausea, vomiting, stomach upset, diarrhea, all of those things. But mostly the ones are the cognitive ones that we find. With Lyrica, the other thing that has come up a lot is depression and even suicidality. Not so much with gabapentin, but remember that gabapentin is just a lot less prescribed than Lyrica. So that's why we see a lot more noise, if you like, around Lyrica.
Okay, thank you. So before we finish off, I just want to say thank you very much to our panel for being here this evening. Thank you to all of you for being here as well. Our next evening is going to be on healthy living, so from pain to healthy living, very important, which a Q&A with our lovely friend Julie McCrossan on the 1st of May. And just a reminder that we don't know some of you, so make sure that you're registered. In the back there, up the top, you'll find a registration sheet with email or contact number so we can keep in touch with you. And that there's also opportunity to become a friend of Wolper and also to consider us. We're a charitable organisation. We put on these events and we run a very tight show in the Wolper Hospital. But if you're thinking of us for a charitable donation, we'd gladly accept it, either in your will or estate. On the other hand, please think about Wolper with our Move Well program. And if it's hard getting to the hospital, well, I'm sorry, we're 100% full every day of the week. That's John's fault and Danny's fault. But we're doing a good job, doing a very good job. Thank you and have a good evening.